Good afternoon. It's my pleasure to be here with you. So I'll talk about the standardized practice in pathological evaluation of residual cancer burden, which is an important topic, I think, for the surgeons and the oncologists. So my question is, how often, to the surgeon and the oncologist in the audience, how often do you rely on pathological residual cancer burden evaluation to guide post-neoadjuvant treatment decisions for breast cancer patients? And neoadjuvant therapy response isn't just about tumor shrinkage. So what else should we be looking at? Accurate assessment of post-nat breast tissue for complete response or complete pathological response or for minimal residual disease. It remains a significant challenge for us. So what are the responses after neoadjuvant therapy? The result depends upon several factors like different morphological and molecular subtypes of breast cancer and rates of drug response on the breast and the lymph nodes. So the responses, as we all know, may be complete pathological response or partial response, or there may be no response at all, or disease may progress, tumor worsening. So in PCR, there is no tumor cells in the breast or in the lymph nodes. DCIS is acceptable. It doesn't make any change. We know in medicine, precision is not an option. It is a necessity. So I shall focus on how precision in surgical pathology it changes lives. So there are wide differences in practice in preoperative tumor and lymph node localization by the surgeon, specimen grossing, specimen reporting. We often have to work with little guidance. For instance, many specimens lack a metallic clip or marker to pinpoint the tumor, which is understandable given various challenges specific to our country. Therefore, we must exercise caution. We have to thrive, and we have to ensure accuracy by adhering to international guidelines in our reports. So there are certain key factors for standardizing pathology practice in post-neoadjuvant settings. Like we have to have effective communication with the clinical team, and the breast and lymph nodes should be thoroughly evaluated. If we take one or more sections from the breast, it's not going to work. We have to take adequate sections. Lymph nodes also have to look thoroughly. And then there should be accurate identification of PCR, whether it is really complete pathological response or not, it's partial or minimal residual disease is still there. And there should be proper evaluation of this RCB score and biological cancer behavior, which is very important. So there is an international group named as North American Breast Cancer Group. They have published certain recommendations for the standardization of post-neoadjuvant breast processing and reporting. So they have suggested some grossing considerations, like before going into the tissue, we have to consult the pre- and post-neoadjuvant radiology reports for effective localization of the tumor and assessing its size. And we should have the core biopsy report in our hand, and we should slice the breast specimen. If it is a mastectomy specimen, we should slice it into 5 millimeter, not more than that, 5 millimeter sections. If it is a lumpectomy specimen, we should slice it in 3 to 4 millimeter sections. These are very important, not to miss the cancer, which is a very small one. As we know, in post-nat breast, the cancer may be very small. We may miss it. And also, another thing is very important, we create a grossing map. While doing grossing, we do make a map by a diagram or a digital photography or whatever. And another thing is to identify the tumor bed properly, adequately, and measure its size. So if the tumor bed measures less than 5 centimeter, we have to submit it entirely. And if it is more than 5 centimeter, at least 5 representative sections have to be submitted. These are very important points which I think if I would have some audience in the, from the pathology side, I would be very happy to, they would also be very careful in future endeavor working with the grossing of breast specimens. So now I shall approach some standardized approaches in breast specimens routinely for the lumpectomy and the mastectomy specimens. In case of lumpectomy, we have to, whatever be the shape of the lump, we have to take it as a rectangular thing or rectangular tissue. As the surgeon will send the tissue by having the stitch mark, stitch mark at anterior, posterior, or maybe medial, lateral. The stitches will be good enough to detect what is the anterior surface, posterior surface, superior, inferior surface, medial, and lateral. So 6 surfaces are there. We have to properly color all these 6 surfaces. And this color template may be different from for different laboratory, but we need to color it so that after making the slides, we can see the color under the microscope, and we can say which one is the anterior surface, which one is the posterior, or the medial or lateral, whether the tumor has gone on the inked margin or not. So this is important. And after doing the inking, we measure the size of the specimen, then we cut it into pieces, and if it is a larger one, we have to put it for another day for fixation. And finally, we have to cut it into thin slices of 3 to 4 millimeter sections. And the remote 2 slices, we have to cut perpendicular to them. So this is very important to include the tumor bed. We have to identify the tumor bed on the slices. We have to make a grossing map so that we can easily track which part of the tissue we are examining under the microscope. So we need to see the biopsy clip site. We need to look for any calcification over there. So ultimately, by cutting into 3 to 4 millimeter slices, we have to then choose the slices which we have to take for the further procedure. And these slices are large enough, we have to bisect it and and then proceed with them for processing. So these are very critical and very important for the patient's point of view, because if we miss something, who's going to suffer? The patient is going to suffer. We are not examining properly the margin. If the margin is involved in a lumpectomy specimen, if we cannot say whether the margin is involved or not, then it's going to take problem, there will be relapse. So this is a post-neoadjuvant mastectomy specimen. Here also, we have measured and then we have colored the anterior surface. We have applied 2 colors on the anterior surface, one on the upper part of the skin, the other on the lower part. We have colored yellow in the lower part and orange on the upper part. And on the posterior surface, we have colored green. Actually, most of the time in the posterior surface, we color black, but this time I have colored this vibrant color to attract the audience. So this is the posterior surface, and there are some sutures we can see, the superior and lateral, which usually surgeons send with the sutures so that we can orient the specimen before slicing. So we slice it into 5 millimeter sections, and then we put it on the paper. We put the slices and palpate each and every slices very meticulously to look for the tumor bed, look for the areas of calcification, or maybe multifocality or multicentric tumor. So whatever be the case, we have to see meticulously and we have to take sections from any suspicious area. So here, we have taken a photograph, digital photograph, we can see here on the left side, on your right side, I think. This is the digital photograph, and on the photograph, we have demonstrated the areas from where we have taken the sections. And we have found the tumor bed, we have measured the tumor bed, measured its distance from all the margins, and then we have demonstrated on the map that where from we have taken the slides, so that when we go back to see the slides, we can come again into this photograph in our hand and see where we found the cancer focus. So in here, there are 2 red spots we can see on slide 3, and another red spot on the section 7. So these 2 spots only we found cancer, so which I will be showing you later on. And also we take another section from the nipple areolar complex. So whatever area we have found some sort of thickened area or fibrocystic areas, we have taken sections from them. So margin involvement is another very important thing. There are CAP and ASCO guidance. They have suggested that negative margin as no tumor cells on the margin. That is negative margin. And if there is no tumor cell on the inked margin, it can be considered margin is negative, even if it is less than 1 millimeter away. However, NCCN suggests that it will be better that the tumor be at least 2 millimeter away from the margin. And also, the evidences suggest that the wider margins in lumpectomy do not reduce local recurrence compared to no tumor on ink. So wider margin is no more, advised by, it's not very recent, it is again, it's a paper published in 2014 by the Society of Surgical Oncology, American Society of Radiation Oncology. They have suggested that wider margins of lumpectomy do not reduce the local recurrence compared to the no tumor on ink. So it's very important to look for the tumor on ink. If there is a tumor on ink, its extent should also be measured, how much involvement is there. So there are certain informations which should be included in a structured pathology report, like size of the residual cancer, percentage of total cellularity, percentage of in situ component, and the closest margin and its distance from the tumor, number of involved lymph nodes, the largest metastatic focus, histologic tumor grade, RCB scoring, and RCB class, and also the AJCC staging. So what is RCB scoring? It's a residual cancer burden calculator offered by the MD Anderson Cancer Center in Texas, USA. Here, if we give the input of tumor bed area, overall cellularity, and percentage of cancer that is in situ, and the position of the lymph node status, and it will calculate and will generate 2 scores. One is the residual cancer burden score, and the other one is the residual cancer burden class, which is very important for the oncologist to determine what to do next. So microscopically, to determine the tumor bed area is also another important part. Here the light yellowish part is the grossly determined tumor bed area, and the purple areas, these spots are all the cancers. So we need to see whether the microscopic and the grossly determined tumor bed area are the same or not. In circle A, it's almost same, but in circle B and C, we could see that the microscopic tumor bed area is a little bit larger than the original site of the, which was grossly assessed as tumor bed area. And in circle D, we can see sometimes the tumor bed area looks bigger, but on microscopy, we can see it as the tumor has has undergone shrinkage. So we have to readjust the microscopic tumor bed area. And also in case of multifocal cancers, there should be ample amount of breast tissue or adipose tissue in between those. And they should be measured separately and documented separately. And we should do the residual cancer burden scoring of the larger site. And also we should do the AJCC staging of the largest tumor. This is a estimation of cellularity offered by MD Anderson Cancer Center. They have these are the computer-generated pictures, which helps us to calibrate ourselves to how the cellularity should be counted. And here is a case which I have shown the gross a little while before. That breast specimen showed very little amount of cancer I have showed you before. So here we can see in situ component was seen at one focus, and another focus we could see some invasive cancer, and we have done the CK5-6 to be sure. And so here we have calculated the residual cancer burden and the residual cancer burden class. And then we have found 22 lymph nodes from that mastectomy specimen. All of them were negative. And so it was RCB1, which can be considered as minimal residual disease. So if you do not take many adequate sampling, you may miss that one focus, single focus of invasive cancer. Then you can call it complete residual, complete tumor residual, no cancer burden. It's a complete response, but actually it's not. So the pathologist plays a very important part in doing this, dealing with the tissues. It's very important. So it's better to, here I am showing the dotting of the perimeter of the cancer can help in measuring the cellularity. We can dot in these cells. If the tumor is larger, we may need more slides. There are 4 slides over there on the left side. We have to dot the perimeter of the cancer, and then we have to look through the microscope, and then from field to field, we can take visual snapshots from field to fields, maybe starting from the right up to the left, or from the upper part, then up to the lower part, and then finally we average the cellularity. That is the better way to assess cellularity of a tumor. So this is another case where we can see that there are few very small focus of DCIS, and also the lobular cancerization is there, and the cancer cells are here and there, and we have estimated it to be about 30% cellularity. And then we have found the residual, and DCIS was 6%, and lymph nodes were negative, so we have come across the score of RCB2. That means a moderate type of residual cancer burden. And this picture shows that there are certain areas which we should not count while assessing the cellularity. The middle one, upper middle one, shows the biopsy site, which we shouldn't count, and the lower right shows the cancer, the necrotic area. These should be avoided while we do assess the cellularity of the cancer. That is very important. So there are certain key points on lymph node evaluation. It's very challenging to find lymph nodes in a post-neoadjuvant breast specimen because they become very smaller, so we have to be very meticulous finding out the lymph nodes. And all lymph nodes should be submitted entirely. If it is more than 2 millimeter, we have to take 2 slices. If it is 1 centimeter lymph node, we have to take maybe 5 slices. So if we have to section them at 2 millimeter intervals. It's not most of the practices are that we take one slice from one lymph node. That is totally, we may miss the smaller foci or micro metastasis. So it's important to make 2 millimeter interval slices. And also we may sometimes need some additional techniques to determine whether there is involvement of the lymph node or not, like we have to take additional levelings, or very occasionally we may have to take help of immunohistochemistry also. So you have to record the number of positive lymph nodes, measure the largest metastatic site, include details about the lymph node metastasis, whether there is extranodal involvement or extension, whether there is micrometastasis or even isolated tumor cells in the lymph node will preclude the diagnosis of complete pathological response. So, a few words about the receptor status, which are being discussed several times in this seminar. Yesterday also, there were some discussions about it, the receptor status. There may be differences in receptor status between pre- and post-neoadjuvant systemic therapy. This is possible. And why it is possible? There may be technical failure, yes. And there may be intratumoral heterogeneity of marker expression. And also there may be some therapy-induced changes. And if there is discrepancies, the patients with residual disease who have initially showed negative receptor status should be retested. Actually, whatever be the, if the core biopsy shows negative receptor study, then in those cases, I think post-NAT tissue should be retested for receptor study. And if there is any discrepancy, we should consider the pre-treatment biopsy sample to be tested again. So that is the best way to deal with the discrepancies or receptor problem. So I conclude here with my greatest and sincere gratitude to my colleague and laboratory staffs for their invaluable support and contributions throughout this work. Would like to acknowledge the following books and websites. And thank you very much for your time and attention.
Madam, upper person. Madam, please.